Many thanks to our sponsors who make this festival possible. A good goodbye. Funeral planning for those who don't plan to die. Bernalillo County and the Indigent Program, the Better Place Forests Organization, Bosque Trails Hospice, Conscious Crossroads End of Life Services, Death Doula Professionals, End of Life Options New Mexico, French Funerals and Cremations, Keeper Memorials, thank you for handling the Zoom on this whole festival, and Passages International. So this is our panel on medical aid in dying with representatives from End of Life Options New Mexico. Take it away.
Thanks, Gail. And thank you all for staying. I know the weather's kind of questionable out there, so it's warm. We're thrilled to have you guys here. So yeah, we'll each introduce ourselves, but one thing I want to say, like today, the theme was unplanned death. And as we work through that today, it's really occurred to me that in a MAID situation for the family, it can often feel like an unplanned death because MAID is still so new. And when they find out their loved one wants to do MAID, it can really be a shock to the family. So a lot of the concepts we went over today really do apply. So it's not this out of sync with the rest of the day as I first thought it might have been. So I'm going to let my esteemed colleagues introduce themselves.
My name is Leah Becker. I'm a physician assistant, and I'm honored to be grouped with the End of Life Options New Mexico crew, but officially I'm one of the co-founders and the executive director of Rites of Passage. We're a nonprofit dedicated to serving all New Mexicans affordably when they are interested in exploring the option of medical aid in dying and other end-of-life choices.
I am Deborah Dugan, and I'm a client support volunteer with End of Life Options New Mexico, and I've been there about 2 years now. Somewhere, a while. But it's a pleasure to be here with you all this afternoon. It's a pleasure to be here with you all this afternoon.
And I think I've talked a lot over the last couple of days, but I'm Sherry Burns. I do volunteer with the End of Life Options New Mexico, and I, as a client support volunteer like Deborah does. And I do serve on the board, and I also recently joined the board of Rites of Passage, which is a real thrill. And I do also volunteer at Scott's House. So if you've heard of community model hospices, I work there also. So a little bit about End of Life Options New Mexico. We were formed in April of 2021. The organization formed as a result of the grassroots movement to get death with dignity legalized in New Mexico. So there were a lot of people on the ground working to make that happen. And once the law was passed, then a lot of those same key people formed this nonprofit organization, End of Life Options New Mexico. We received our 501c3 designation in 2022. Right now we have a little bit more than 60 volunteers. Some of our volunteers do what's called public outreach and education. So everyone who's been manning the check-in table is part of that team. So they go out and they attend festivals, they do talks, they do tabling. And then there's a team of 11 of us that actually do client support. So we have a warm line that's answered 9 to 5 on weekdays. People call in or they can email. We get all sorts of calls. Maybe people call because they just found out they have a terminal diagnosis and they just kind of don't know what their choices are. So they may call us. We may get people who call and say, I want MAID now. I think one time we had someone say, yes, I'm calling to sign up for MAID. So when people are interested in medical aid in dying, they get assigned to a client support volunteer, and we work with them through that process. Or if they're just calling to find out what their options are, again, we get assigned and we'll go visit them or talk to them on the phone and help them understand what all their choices are given their current diagnosis and their situation. So our vision is that New Mexicans have accurate information and caring support to choose their end of life options in a system that will honor those choices. Our mission is that we provide information and support for all end of life options, and that includes medical aid in dying. It includes all the things we've talked about over the last couple of days: BSED, palliative care, hospice, continuing treatment, discontinuing treatment, all those different choices we support. So as far as services that we do, We do train clinicians on MAID, so MAID is still a relatively new thing in the state. A lot of clinicians may want to start practicing it, but just aren't sure how. We can set them up with another provider who does MAID so they can be mentored, or we can train them. Deborah and I actually trained the first time she did a MAID ingestion. We do community outreach and education, like I mentioned. As far as client support, like I said, we help them review all their available options. We do have a very extensive provider and hospice network. So some of the calls we get are like, I'm terminal, I don't know this, that, or the next thing. How do I pick a hospice? And that was some of the discussion I think yesterday is like, how do you pick a hospice? So we have very extensive directories. This hospice does this. This hospice does this. This one actually has someone who will prescribe, like Bosque Trails, or this hospice will discharge you or transfer you to another hospice if you want to do MAID. So we have that kind of information. So if people call us, we can help. We don't make clinical recommendations or anything, but we can give them information on hospices and help them find the right one. We also have extensive directories of prescribers who will prescribe. So I think I heard someone ask the questions like, how on earth do I find 2 doctors? We can help you with that. We'll explain the law, we'll walk through the hospice part of it, and then we can help you with the directory that we have of helping you find a prescriber. We don't always send everybody to Leah because then she would be overwhelmed. We also provide support for an actual ingestion. So we're a pretty rural state. A lot of our clients are in remote corners, and a doctor who's prescribing may want to attend, but they have a full schedule of patients to see every day, and a client calls and says, I think tomorrow's the day. Well, that doctor's not going to go off and cancel all those appointments and travel to Roswell and stay overnight and attend the ingestion. So in those situations, they can call us and we will send volunteers that actually do the ingestion. We'll mix the meds, we'll pick them up to the pharmacy, mix the meds and be there with the person. So that's a big service that we provide to try to help never keep them. And we also provide emotional support for family members of anyone who's terminal or considering doing MAID. So those are just some of the things that we do, and love to hear from you if there's anything we can do to help. Okay, so what we're going to do today, we're actually going to do a reenactment of some of the key points in qualifying for MAID. So one question, how many of you attended the MAID presentation with Dr. Rankin and Dr. Fitz? Okay, so quite a few of you did. So some of this is going to be a little bit repetitive for that, but hopefully you'll see, like from the reenactment, it'll give you more of a sense of what this is really like instead of just hearing about it. You'll kind of watch it. And one thing we want to say, watching a reenactment might be triggering. So if you have concerns about that, we certainly understand. If you want to step out of the room just because it's a little too triggering to watch a reenactment, we certainly understand. So the scenes we're going to talk about is the initial appointment. So the client is called in to End of Life Options New Mexico and is assigned a client support volunteer. And the volunteer is going to go see the client for the first time. We call them clients because we're not clinical. Then the next scene is going to be the initial meeting and assessment with the prescriber and the client. And then the last scene will actually be the MAID ingestion. So any one of these appointments, especially the first 2, would probably last, a real life appointment would last 45 minutes to an hour or more. And we have 1 hour for our presentation. So we're going to try to condense these down to about 10 minutes each. So there's a lot we're not going to be able to cover, but hopefully you'll get the idea. So our patient is Barbara. Did I get that right? Barbara?
That's right.
Barbara did not use her real name. And then I'm going to be the client support volunteer. Hi, Barbara.
Hi.
I'm Sherry.
It's nice to meet you.
How are you today?
Okay.
Are you?
Yeah.
So you called End of Life Options New Mexico, and our dispatcher assigned your case to me, and I just chatted real briefly, thought we know some person.
Yeah.
So can I ask you, can you kind of describe to me what you understand your situation is, your health situation?
Yeah. I have stage 4 metastatic breast cancer.
Okay. And has someone talked about the prognosis or
Not
what do you
good.
understand?
Not good.
Good.
Yeah. I understand that it's it's now in my lungs and recently in my brain.
Okay, so it has metastasized here.
Yes.
All right, that's good to know. Are you on, you're not on hospice yet?
No, I'm not on hospice. I don't think I need hospice. I'm not dying. I'm going to a wedding in a couple of months and
Okay,
yeah, I've got time.
okay. So just to talk to you just briefly about hospice, and we can talk about it plenty of other times too. It can be alarming when someone says, aren't you on hospice? Because it sounds like someone's telling you the end is here. The way I like to think of it, and I don't know you well, but you strike me from our conversations like kind of a private person.
Yeah.
Yeah, so I had a similar situation with my parents. They were very, very private people. And my dad didn't sign up for hospice till it was really, really late. And it felt to them like their home had faded. Like one day it's just him and my mom, and the next day it's a hospice nurse, it's a social worker, it's a chaplain, it's bath aid, and all this equipment showed up in their home. So by signing up for hospice earlier rather than later, you kind of avoid that feeling of loss of control. And that feeling like the whole world has descended on you and taken control of your life. So at this stage, if you signed up for hospice, you'd be assigned a nurse, a social worker if you want one. And it would be taken at your pace. Like right now, you're still feeling pretty good. You're gonna go to a wedding. So you might see the nurse once every other week. But the thing is, you'll have worked with her over time and you'll form a relationship with her or him. And there'll be this growing feeling of trust and you'll get to know the staff. So it won't feel like a whole bunch of strangers suddenly descended on your life. So just think about that, you know, the sooner the better. It doesn't mean the end is nearer, you know, it just means, you know, that you get some support.
So you said that you had family members that signed up late. What does late mean?
So just to continue with my situation, so my dad was a large person, he was like 240 pounds. My mom was like not even 5 feet tall, weighed 100 pounds. The physical exhaustion of her helping take care of him took a toll on her.
Okay.
So really, we signed up for hospice as a help to my mom. So when it reaches that point where if you have some family around and people who help support you, but when it gets to be too much, you need a break, or there's things you need that maybe they just don't feel qualified to, like if there's like, well, I don't want to help give a bath or something, then it's a good time. Like when, as you start, and you can take it in steps. Like at first you're just seeing the nurse and they're helping, making sure you're not having pain, you know, and then as the pain increases, then she'll come see you more often, the prescription, manage your prescriptions, reaches point, need a bath aid, then you'll get that. But it becomes a much more gentle, gradual journey instead of a
sort of progression.
Right. So just, you know, as you consider it, think about it that way.
And if I decide that I'm interested in looking at hospice, can you help with that?
Absolutely, we sure can. And you're wanting to do medical aid in dying is a big factor. So I'm not gonna suggest to you hospices that don't support MAID, because I would hate to see you get registered and then have to transfer to a different one. So when you're at that point, I'll give you a list and I'll kind of tell you the pros and cons of each one. And make that decision.
Okay, that sounds good.
Yeah. And then, so what's your situation as far as like your primary care or your oncologist? Are they on board with your decision?
I haven't really talked to them about it
Okay.
so much. They've been very supportive so far.
Okay.
So I think they will be, but I don't know for sure.
Okay, so it's really up to you. Like if you want to reach out to one of them and say, hey, I want to do MAID, would you prescribe? You can certainly do that, but you also don't have to. We can help you find.
Okay.
Refer you to a prescriber too.
Well, I have an appointment next week, so I could ask.
Oh, do you? Okay, yeah, great. What else did I want to ask you about? So does your family know what your plans are?
Yes, we've talked about it.
Okay, and are they supportive?
Yes.
Yeah, okay. What would you say are the red lines, the lines in the sand that would make you decide now's the time? And just for example, you're going to a wedding, so obviously you want to make it to that. For some people, it's like when it reaches the point of having a diaper, that's a hard one for people. Or if you're bedbound, that can be a hard one. So do you have thoughts about what that red line is for you?
I don't know, I might have a few initial thoughts. I definitely don't want to be bedbound. I think that if the pain is intolerable, then I've been pretty sick in the past. I'm doing pretty well right now, but yeah, I wouldn't want, and I don't want to be a burden.
Sure. Well, and again, hospice can kind of help relieve some of that, so it doesn't feel like you're a burden to your family. One thing that's kind of difficult to talk about that I'd like to mention, since we talked about red lines, you said that you have metastases to the brain.
Yes.
And so when we talked on the phone, I went through the requirements to qualify for the law, and we talked about decisional capacity. So once you have metastases to the brain, that can affect your decisional capacity really quickly. So a commitment that I will make to you as you and I work together and as I come to see you, when I see signs that maybe those metastases are affecting your decisional capacity, I will let you know.
And by decisional capacity, you mean that to be able to make the decision to take the medication?
Right, like right now, talking to you today, I can tell your decisional capacity is fine. You know, and from our conversation on the phone, you know what you're asking for, you know what the medication's gonna do. You have some thoughts about what that red line is. So even though I say that today, maybe you'll see a prescriber tomorrow and they also will approve you. But on the day of ingestion, you have to have decisional capacity that day. And that's why when there's brain metastases, we watch that really closely. Because one day you can have decisional capacity and the next day you may not. So we kind of refer to it as the window of opportunity. So you've got me on your team, we'll get, eventually you'll have a hospice, we'll have a prescriber, and we'll all be watching for that. And we will let you know very, very clearly that your window of opportunities is closing. Okay, so it's a hard conversation, but I want you to know, especially since you already know you have brain metastases.
Yeah, no, I don't want to miss the window.
Okay, good to know. Good to know. All right, so do you want me to, with your permission, if you want, I can reach out to some prescribers and give them your contact information?
Yeah, it would probably be good to at least know who might be available.
Yeah, so in Santa Fe, we've got 3 different groups of prescribers. What they charge ranges from nothing to donate or fees based on income. And then there's 2 doctors that charge a flat fee of $2,500 to support MAID, and then the prescription costs around $550. So, any initial thoughts about which prescriber you might want to reach out to?
No.
Okay, good. So if you want, I can, okay.
Yeah.
If you want, I can make those calls and have them call you.
Okay.
They'll come over and see you. They'll do the official assessment. Fill out the paperwork.
Yeah, if you could send me some information, I'll look at it along with my family and then,
Okay.
then we can let them know.
Okay, I would, yeah, I'll be sure.
Thank you.
Well, thank you, Barbara, and take care, okay, I'll be in touch.
Thank you. Appreciate you coming.
We are going to take questions at the end, but if anyone has a burning question about this little piece that we just addressed here, go ahead and speak up.
You have to be on hospice in order to do the medical aid value, and will insurance pay for anything?
I have a feeling that our patient is going to ask some of those exact questions in our next vignette. So hang on to that. If we don't address it by the end, please remind us. Anyone else with any questions? No? Okay. So this is the second vignette in real life. I'm a medical aid dying prescriber. The New Mexico law very generously allows nurse practitioners and PAs, mid-levels, to prescribe if the patient is already on hospice.
And we don't want to disturb your vibe, but if you could speak up for the benefit of the people who are watching on Zoom,
Great.
that would be great. Thank you.
Wave at me vigorously if I neglect to do that. Hi, Barbara. My name is Leah Becker, and I'm a physician assistant. And you and I spoke on the phone. You were referred to me both by End of Life Options New Mexico and by the hospice that you have joined. One of my favorite hospices, by the way, so I know you're in good hands. Are you still interested in pursuing medical aid in dying?
I am still interested in at least talking about it, yes.
Sure. So let's review first of all what the eligibility requirements are.
Okay,
And then let's get into talking about your particular situation, but I don't want to waste your time if you're not eligible on the face of that. So obviously you are an adult, you're over 18 years old.
yeah,
You and I are meeting here in the boundaries of the state of New Mexico. So you have residency.
yeah, I've been here a long time.
And you've been here a long time, but I want to say that even if you hadn't been here a long time, if you just got here last week, but you basically live here now, as far as the law is concerned, you are a New Mexico resident. So we're good on that one. You told me over the phone that you have breast cancer, is that right?
That's correct.
Okay. So are you still in treatment for your breast cancer?
No.
Okay.
No,
Okay. So you've been admitted to hospice because you decided to stop treating your breast cancer. Yeah. And the hospice agrees that you are liable to die naturally of this disease within the next 6 months. Is that right?
that's what they say.
Okay. Do you believe that?
I don't know. I definitely feel worse than when I first signed up with hospice, so it could be 6 months. Less than 6 months.
Okay. And then the last piece is about decisional capacity. So I want to be really clear, because I know you do have some metastases to your brain. I don't care if you know what day of the week it is. I don't care if you know where you put your car keys. I don't care if you can't find your glasses or a pen. What I want to know is, how long have you held this value that a person should be able to hasten their death to avoid inevitable suffering?
I've held it for a very, very long time. I watched my dad struggle with his death, and he would have chosen differently had he had this option. So it's been a long time ago.
And is that holding that value, is that something you've discussed openly with your family? I know your imaginary sister is here with you today as well.
Yes, yes, we talked about it.
So this is not a surprise
No.
to your family.
No.
Is there anyone in your very close circle of friends or family who you would be uncomfortable sharing this decision with?
There are some people I wouldn't talk to it about, but only because it's really none of their business.
Right. So I want to just reflect that in the way you've spoken to me just over these past few minutes, it's clear that you have decisional capacity. You understand where you are in the course of your illness. You understand what the situation is. You understand the legal issues and their interpersonal issues. And this is a firmly held choice that you have valued as a basic principle for some time now. Okay. So in my opinion, you are eligible, not just because you are registered with a hospice, which is an implication that you have 6 months or less to live, but also because you meet all these other criteria. I do worry with all illnesses, but especially when there are metastases or any involvement of the brain or thinking, that you may lose some of that eligibility as time goes on. Have you been noticing any changes in your brain function?
I don't know so much that I've noticed them, maybe a little, but the people around me have commented about some confusion. So,
Can you be more specific? Do you remember what kind of confusion they noticed?
just forgetting things like I was here yesterday. And, when I'm reminded, I remember.
Okay. And, you know, I want to just reassure you that doesn't play into your ability to use medical aid and dying. Okay? Again, it's about your sense of self, your sense of your decision, and your sense of your values. One more piece about eligibility for medical aid in dying is that you have to be able to get the medication into your body. Our New Mexico law is one of the most generous and liberal in the entire country. And anyone who's helping you at the bedside, in this case myself or the community support volunteer, we are allowed to support your body if, for example, you're not able to manage holding the cuff. We're allowed to help you hold the cuff, but we need you to reach for the cuff and do your damnedest to try and get it to your mouth. That's your decisional gesture, so that we know you are doing this entirely on your own volition. Okay. Yes, what's your question?
Can I ask a question about that? I've had a lot of nauseousness lately, and hospice has been helping with that, but what if I can't swallow it?
Right.
What if I can't keep it down?
Okay, that's such an important question. So yeah, so mostly people who are able to swallow will drink the medication, and it comes just as a mixture of about 2 ounces, and nothing's perfect. It's bitter. Some people describe it as kind of burning, and yet I have never seen anyone stop the process due to that. If someone is determined that they are ready to hasten their death, that flavor is nothing that's going to stop them. And we can make it easier by giving you bites of a cool sorbet in the process. Nausea is a really important piece of it, not because being nauseous in the moment or even throwing up the medication is really going to change the outcome. You will die just by virtue of drinking it. But I don't want your last minutes to be that kind of visceral yuck discomfort in your stomach, or for your loved ones that you may choose to have with you, for them to be watching you suffer with some vomiting. So if you are able to swallow mechanically, we will give you some 3 pills at least half an hour before you drink the aid in dying medication, and that will calm any nausea. It's not uncommon for people who drink the medication to have a lot of burping. I have, heard people reflect about the flavor. Oh, it's just worse than I thought it was going to be, or ugh, I like Scotch better. Some good comments come up from it, but again, it has never stopped anyone, and we can make that better with the sorbet. In the case of folks, and this could happen to you, depending on the metastases and just your progression, in the case of folks whose nausea leading up to that day is just uncontrollable, or who mechanically cannot swallow, the aid in dying law requires that you ingest the medication, and that's a medical term. That means it has to arrive in your body through your digestive tract. But we don't really care where in your digestive tract. So if you can swallow it, that's great. If you can't swallow it, we can help you deliver it through a very small tube in your rectum. It's basically the same size as a urinary catheter that you might have had in some previous hospitalizations. It's smaller than my finger. And in that case, we would prepare you by having you get an enema the night before to clear any stool from your rectum. And we can just, on the day of ingestion, just very discreetly place the tube, make sure it's sitting properly, and it will cover you back up. And so you could still have friends and family in the room without any undue exposure. Okay? And in that case, there'll be a syringe, and it will still be your decisional gesture to press down on the syringe to deliver the medication into your digestive tract. Does that resolve that question for you about swallowing?
Yeah. Neither one of them sounds very appealing, but it does resolve the
Yeah.
question.
I've never yet met the person for whom it sounded appealing. And I've never yet met the person who felt strongly that they needed to hasten their death, who in the moment didn't say, oh, that was easier than I thought it would be.
It's good to know.
And we're really sensitive to your dignity and your choice in the matter all the way through. We ask you the questions ad nauseum. Sorry to reflect on that, but we say, are you sure this is what you want? Is this the day you want to do it? Are you still feeling good? We check on your decisionality. We check on your ability to swallow, and we really make sure not only are we abiding by the law, but we're paying all the respect to your autonomy and your choice. And that's such an important gift for you to give your family and the folks around you.
So I've heard just a couple of more questions. So I understand that you can write the prescription and it can stay there until I'm ready. How much does it cost?
Yeah, so the prescription itself can cost as much as $550. Are you by any chance on New Mexico Medicaid?
No.
You're not. Okay, I'm sorry to hear that, because folks who are on New Mexico Medicaid, not with wraparound Medicare, but just New Mexico Medicaid, actually can get that prescription covered by New Mexico. It's a state benefit, but medical aid in dying has not been approved legally at the federal level, so Medicare does not cover that. So your out-of-pocket cost for that would be up to $550.
And I'm assuming my insurance won't cover it.
No private insurance covers it anywhere in the States yet.
I guess my other question for you is, how will I know when it's time?
Well, most importantly, you're the only one who will know when it is time. And it's a little bit like a young person asking, how will I know if I'm in love? You'll know when you know. Many people have a list of things that they want to accomplish or take care of or dispose of before they die. And the folks who express that they are not ready, that list is still really present, a significant part of their day-to-day reality. Folks, as they get closer to being ready to die, tend to kind of cross stuff off without even bothering to do it. Or they look at the list and they say, I'm not sure, I'll deal with it another time. I don't think that matters today. So as you start to notice that you are letting go of some of the things that you thought were most crucial about staying alive, those can be signposts that you yourself are getting ready. You'll know when you know, and we will trust that you know.
Thank you.
Thank you for letting me participate. So just call me when you're ready.
Okay.
And we'll keep an eye on you in the meantime.
How much notice do I need to give you?
You know, we're a small organization, so we appreciate at least a couple days notice, but we try to always have a provider available pretty much every day of the week. So we'll just stay in touch, and we'll be keeping an eye on you as will the community support volunteers. So we'll be watching you and letting you know if you're in danger of losing eligibility.
Thank you.
Okay, thank you. And again, just briefly, if there's any questions that we didn't address in that vignette. There are separate charges. So the prescription itself is, if it's not covered by New Mexico Medicaid, costs up to $550 out of pocket. Prescribers can charge anywhere from nothing to, in this state, the upper level is $2,500 for their services. And usually that fee, whether it is nothing or $2,500, covers the conversation that we would have had with the patient before we got there. It covers speaking with the patient on the day of assessment and evaluation. It covers communicating with any of their other providers, like their hospice team. It also involves communicating with family members who we are given permission to speak to if the patient wants us to do that. And for almost all providers in New Mexico, it covers the provider being present on the day of ingestion. That's not a legal requirement, but as long as it's a oral ingestion that the person is going to be drinking, not ingesting through their rectum. Community support volunteers are more than capable of overseeing that process. But I venture to say better than 90% of the prescribers in New Mexico hold the value that there should be a medical eye, a trained clinical eye in the room, watching and confirming that everything is going according to plan. Yes. Thank you. Yes, if you are on hospice, your path goes a little more smoothly because then not only can an MD be your prescriber and your secondary confirmation of eligibility, but also a mid-level, like myself, a PA or a nurse practitioner can be that person. If you do not choose or are not willing to be on hospice, then you must have an MD or a DO licensed in New Mexico to be the first person who confirms your medical eligibility and your terminal prognosis having approximately 6 months or less. And then you must also have a second MD or DO, but mid-levels cannot be prescribers in that case.
If I can just add on the hospice, sometimes we have people who are on hospice, but it's not a hospice that will prescribe MAID medications. So then we have a hospice, but we need a secondary person as well, or secondary, it can be a mid-level person, but so it can, sometimes we have hospices that we call them the full service hospice. They will prescribe and others and do the whole process. And then we have hospices that won't prescribe.
Hospice companies and list of hospitals. Will say no, you know, do medical.
We
he said yes, but I work for locals. Locals won't allow me to.
Could you repeat the questions or?
Yes, she's asking about lists of hospices that will and won't support medical aid in dying, and also the extent of that support. And it is true that there are some doctors who would be willing to prescribe, but their employer doesn't permit them to do that on the employer's time. So, and correct me if I'm wrong, Leah, but yeah, so it's a complicated thing. And I just want to say one more thing about our lists. We do have, I mean, we try and keep track of them, but it changes. Hospices change ownership, hospices have new management, and they did support and now they won't, or they will to this level, or they won't. So it's a constant thing for us to kind of keep track of that. Whenever I refer people to hospices, I call ahead and say, we have a list that says this, is that still true? Because it's a moving target. No, we can't post it. You call End of Life Options New Mexico and talk to the dispatcher and they can help with those things.
We're gonna go ahead and move on to our last segment. Would you like to be in bed? Sure. Well, why don't you, you're head of the bed here, instead of the bed there. Okay.
Just so while we're getting ready, I know you guys have heard some things, so lockbox. What I do when I'm mixing, so I have a little espresso cup, so I measure my 2 ounces of apple juice, pour it into the bottle, and then there are some people who actually put this.
They want to be right now.
Okay. Right, I got all geared up, but it's not. Okay. Okay. Put it right in there. There's some providers who put the straw like straight in the medicine bottle, and that just bothers me aesthetically. Like, this person is dying. I want things to be nice for them. So I bought a whole bunch of small stemless wine glasses, and that's what I give the medication to my clients in with a straw. On one occasion, Deborah and I were both at this ingestion, but there was like 25 people in this tiny little house. And so we tried to go prepare the meds, with some kind of privacy. So we ended up going out on the front porch. And it was a time of day when the sun was coming at us. And as I poured the apple juice into the bottle, I saw that powder come puffing up out of the bottle, and it's lethal. So since then, I always wear a mask, always put on gloves. And sometimes then when I walk in the room with the patient, they're just like, why are you all like geared up? And I'm just like, well, I'm giving you this really lethal medication. And I'm like, oh, okay, we get it. Okay. Let's see. That was another question, sorry, I really normally ask this question. So,
Thank you, never mind.
sorry, a little stage fright, that was not really a question I would know. I might ask the family how they're doing. Glad. So do I understand the hospice was here earlier and gave you the anti-nausea meds?
Yes,
Okay. And so do you know who I am?
I do. You're with End of Life Options New Mexico.
Right.
You're sharing.
Yes. And what's your understanding of why I'm here today?
You have the medication that I'm going to take.
What's your understanding of what will happen if you do take?
I will die.
Do you want to go ahead with that today?
I do.
Okay, I'm gonna step out, mix the medications for you. And this is really your time with your family, so I invite your family to come in and spend some time with you while I go get everything ready, okay?
Okay.
Just because we're aware of the experience of watching someone pretend to die, we're gonna, if I could douse my candle, which I might have. What's working? We're just lighting a little candle for Barbara's death. And later on, when we want our colleague Deborah to come back, we'll extinguish the candle.
Okay, Deborah, so I've got some sorbet here, it's raspberry flavored, so the void is like, you'll take a spoonful. I suggest you hold it in your mouth for a while, the cold will kind of numb your mouth, and that sweetness will kind of overwhelm your taste buds. And then after you do that, then I will give you the medication to take. You need to take it all within 1 or 2 minutes. Otherwise you run the risk that you fall, because it'll put you to sleep pretty quickly. And if you haven't taken it all and you fall asleep, there's a chance you might wake up. It's never happened, but it's just, we really have to get the whole thing down. And then we'll follow up with sorbet, okay?
Okay.
All right. Do you have any concerns? I feel like I heard you were concerned about nausea.
Yeah, I mean, I took some medication for that, but yeah, I really don't want to vomit.
Right. So Leah, you think we're okay doing it orally?
We're just fine. Your nausea is well controlled. And I'm trusting the process. I've seen it so many times and I have confidence that this is going to work for you if it's your choice.
Okay, alrighty. So I'm gonna ask to see if any of your family would like to be the ones to give you the sorbet, because it can be kind of a comforting thing to comfort their loved one. So I'll just pretend here for a minute I'm your sister. Okay, go. Yeah, let that get your mouth nice and chilled. Okay, alrighty. Is it burning? Do you have a burning sensation? If you want, I can give you a little more sorbet in between.
No, it burns. It's bitter. It's very, very bitter.
Yeah.
Wasabi.
Get some more sorbet in you. Just hold that in your mouth.
And I just want to remind Barbara's family that over the next 2 to 10 minutes, she's going to be falling into a very deep sleep. And when she falls into that deep sleep, she will then fall rapidly into a state of unconsciousness. We may hear her make some funny snoring. Her arms may gesture in funny ways, but if we look at her face, we'll see that she's deeply, deeply relaxed.
Taste, it's back. It feels sort of warm now.
So the burning's starting to go away a little bit.
Little bit.
Often invite family members to get in bed if they're not already there and snuggle and get close to their loved one. She's beginning to fall asleep. Since she's in pretend bed, my hand will be pretend pillow. We might see some color changes in a real case, or even some dark reddening or even significant paling of the skin color. Wide range, that's totally normal, including nothing happening. And now I see her hands are starting to relax. If a loved one was holding her hand, they would have noticed that she was kind of loosening her grip on them.
Sometimes with the color changes, it can be in their hands, like their hands and feet might turn mottled pretty quickly. For me, I'm not clinical. I do carry a stethoscope, but one of the things I've learned to watch for right away when they fall asleep is for to see if I can see the heartbeat in their neck. Because that way I can stand back. I don't have to be too close. The family can be around. I can stand back from a distance and watch that heartbeat.
She's very cooperatively demonstrating a gentle snore. Someone less or even more ladylike might sound kind of like someone with a big smoker's cough after 40 years. Even just a wee little thing could go. And it's usually good for a little giggle in the family, as long as someone is there to say, hey, that's normal. This is just part of how the medication is working on your loved one. The medication is formulated specifically so that the most sedating ingredient hits the body first. Therefore, the person does not have any experience, physical experience of the rest of the medications. From this moment on, we would consider that Barbara is deeply unconscious and has no more physical suffering. People who weren't able to hold her closely before because of the bone pain of her metastases can now really hold on to her and love on her if that's appropriate in her concept of how she wants to be managed and in their worldview. On average, it takes about 2 hours from this point to her actual death. It can take much, much longer. And we watch out for those cases that can be kind of predicted by some pre-existing medical conditions, and we screen for that at the evaluation. But also sometimes it just happens because it happens and we don't understand why. Similarly, someone could have all of those pre-existing conditions and go within just 4 or 5 minutes after they fall asleep. We don't know why. After a certain amount of time, we'll just then confirm that the person has died. I was really interested to notice when I first started doing this work, coming out of family practice, I still had the idea that the moment of death was like really important. Time of death, 3:02 a.m., doctor. And then a number of families taught me that they didn't care at all about the moment of death. It was just about when they were ready to have me check their loved one for any life signs. And this process of checking the person for their, I'm distracted because I'm used to not hearing a heartbeat now, but she's not dead yet. But if you are at the bedside and a provider or community support volunteer is there checking for signs of life, you'll notice that they take quite a long time. It's sort of suspenseful. And that's because we never want to say ahead of time that your loved one has died when they are still living. In spite of that, even the most experienced clinicians will say, yes, your loved one has passed. And about 2.5 minutes later, the loved one goes one more time, and it's a little abrupt. So preference is to delay that pronouncement if at all possible.
The other thing that happens, I've noticed, that medication is very toxic and it's in their digestive tract. So sometimes you put the stethoscope on and you hear a whole lot of rumbling. And so then it's really hard to distinguish that. Do they have a heartbeat or not? Yeah, so that can happen. And I've seen clinicians even go, I'm really not sure because I just hear all this rumbling going on.
Exactly, yeah. So with the interest of time in mind, I'm gonna go ahead and say that our dear Barbara has died. And from here on out, we turn our attention to the family. We respect Barbara's wishes for how we were gonna manage her body. And we respect the family's wishes for what they need to do to process this moment. In this moment, we want our colleague Deborah to come back. So I'm gonna go blow out that candle and invite her to come back with us.
And like Leah was saying, at this point, we really focus on the family. As a doula, one of the things I sort of have a thing about is what I call the machine when it takes over. Things you call the funeral home, you could really kind of lose control of the situation. They're gonna send someone to pick up the body, all these things are gonna start happening. And it leaves you kind of feeling like, what did just happen? So in a situation like this, I really encourage the family. We will take this at your pace. Spend as much time as you want with your loved one. Sometimes they may want to help bathe or actually bathe the body. We can help them with that. But we tell them, we can let the funeral home know that your loved one has died, but we can also tell them, we'll call you when the family's ready. And I get very protective of families to make sure that they get the time that they want and that they don't feel like all these outside forces have kind of taken over the passing of their loved one. So we'll open it up for questions. Yes.
I have a question kind of about the science of the mechanics. They mentioned 2 ounces. Is there I'm assuming there's a good reason that you wouldn't want to put it in a 12-ounce chocolate shake or something. Just too many ounces to drink.
It's too many ounces to drink for folks who may also have some nausea or some impairment in the volume of their stomach. But even more than that, the bitterness and the burning quality of the medication is then distributed throughout the whole 12 ounces. Yeah. And it's just going to cause them. There's not much dilution. We're so grateful to have the, they changed their name, but I'm going to go with the old name because I haven't memorized the new one. The American Clinicians Academy for Medical Aid in Dying, gathering data from all across the country. All providers submit data as best they can on time to death, ingredients that were used. Did you mix the solution with water? Did you mix it with apple juice? Did you mix it with scotch? No, not recommended, but you know, are you going to say no to a dying person?
Keep it down. Like there's no benefit to going up an ounce of plate for the week.
There is no benefit.
It tastes bad longer.
It's going to taste
down at all.
Yes, it's going to taste bad longer if you go up in ounces. And because the Academy has been collecting excellent data from clinicians all across the country for a long time, only in the past 18 months was the recommendation reduced from 4 ounces to 2 ounces. So now it's really just a shooter instead of a more onerous 4 ounces of bitterness. Another question?
You know what? None of us have tried it, so we can't really answer your question. We have to go by what our patients tell us. But the wasabi thing, that was actually this beautiful woman whose home was full of all of her loved ones. She was laying on the bed, she got very quiet, her eyes were shut. And with her eyes shut, she started telling us everything that was happening. She said, my arms are burning, my head's burning. It was such a gift to us to be able to just hear what she was experiencing.
And I will add, she did that so that her family would know she was okay. She wanted them to know what was happening. And she finished narrating. She said, I love you. It's gone.
And she was the one, I think at some point I said, you know, is it burning? And she opened her eyes and looked at me and she said, have you ever had too much wasabi? And I was just like, what are we talking? Are we talking food now? And I just said, well, yeah. I said, it kind of makes it feel like the top of your head's blowing off. And she goes, that is what this feels like. So like I said, it was such a gift to us to have someone tell us the whole thing.
So we have a comment online. This was very helpful for me, Jan Wilson, as I only deal with presentations and information giving. This has really made it more real, if that makes sense. Thank you, and this is why I volunteer with End of Life Options in Mexico.
Thanks, Jan.
And I would like to let you know, my mother-in-law accessed medical aid in dying back in July. And according to the hospice nurses, she had like one of the worst reactions to the burning and the bitterness, and she like swallowed half of it. And my brother-in-law was encouraging her to keep drinking it because he was afraid, you know, if she didn't do it, what happens? And apparently, is there a plan B if they don't drink the whole thing?
We really have to come up with a better answer for that question because the question always arises.
Yeah.
So the first answer is reassurance. The potency of the medication is so intense. This is orders of magnitude greater than any of those medications are ever used on their own for treatment. So, you know, if I were to just, you know, accidentally spill a bottle right here, certainly the three of us would die and possibly a few others if you didn't get it under control quickly. Therefore, we are not significantly worried when someone only takes 1 of the 2 ounces. There is an option for kind of a plan B, and it's very, it's a vanishingly small possibility of that happening. There's only a couple recorded events in which the medication itself was not successful in hastening someone's death. And in looking back at the data, thanks again to the Academy, we see that there were probably some pre-existing conditions that were missed. In the case where there are significant pre-existing conditions, the prescriber has the option to make the prescription even stronger. And I have done that a few times when I was concerned about a pre-existing condition, and everything went very, very smoothly, still under 2 hours. In the far off case, in which another pre-existing condition is missed, one of the documents that the patient signs when they agree to do when they request to do medical aid in dying is an official request for medication that allows the prescriber to write the prescription. That, am I right? Or am I just thinking about my own notes? No, that is right. Yeah. That document, which is required by the state of New Mexico, indicates that the patient allows the physician or the medical provider to deliver additional medication should they see signs of lightening sedation. I have never heard of anyone who needed to do that.
Well, and in fact, in her case, she was asleep in like 3 minutes, and within the hour she had passed away.
One of the things I'd like to emphasize is the whole idea that people have to be decisional on the day of. And so you heard me ask Barbara the questions about did she understand what was going to happen. When I first started doing this, I felt really uncomfortable with the loved ones around. I felt like, well, maybe I should ask them to leave the room. But I've discovered it's so important for them to hear their loved ones say, yes, I know what this is, and yes, I want it. Lots of times up until then, the room is really quiet. And when I go through those questions and they answer yes, is when I hear people starting to choke up. And so that kind of made me feel bad. But like I said, I've learned over time, it's really important for the family to be there to hear that confirmation. Okay, Any other question? We got just a second for maybe another question. Go ahead.
Like, complexity of like, two, taking the two, so that the person's not to bypass the whole factory and everything. If you just do down.
Like an NG tube or something?
If someone has an NG tube or a G tube or a J tube or even a colostomy, those are all legal entry points to the GI tract. An NG tube in itself, inserting it is so uncomfortable that we really would not go to that first. If someone I always bring supplies for rectal administration, because if on the day of it's unexpected, but the person is unable to tolerate the medication by swallowing or by nausea, then we can switch to a rectal administration. It's truly very simple. And, most of us have been to the doctor's office and had a rectal exam. Women often go through a lot more than that. It's so much more discreet and simple and respectful than you might think of it, that's very much preferred. I would never impose an NG insertion on someone who could just have a rectal tube instead.
One more online question. In the case of all the medication not being taken, is there a possibility of a negative reaction from the body? Convulsions, vomiting, etc.
The wonderful and terrible thing about this formula is that even for example, it has morphine in it. Folks who are allergic to morphine will actually become significantly sedated by the other ingredients before their allergic reaction is stimulated. And in fact, they will simply die faster. So those kind of reactions are not a concern. There are sometimes some seizure-like maneuvers that the body will make. Neurologists tell us that that is a signal of different parts of the brain simply shutting down. And again, as we look at the person's face, they're very relaxed and very apparently unconscious of anything their body is experiencing at that time.
You said something about.
Ideally, the patient does not eat anything other than clear liquids for about 6 hours before they take the medication to hasten their death.
Back on the subject of allergic reactions, I did have a client once who did have an allergic reaction. The prescriber was there and she anticipated a really long death for various reasons. It was done rectally and we were all braced to be there for the afternoon and evening. And shortly after he pushed the plunger, he just said, he goes, it itches really, really bad. and the prescriber's like, what? And he just said, it's really, really itching. And he complained about that quite a bit. And then the next thing we knew, it wasn't hives, but yeah, his neck turned red and the redness came over his face. So he was having a full on allergic reaction, but he passed away in about 30 minutes compared to people anticipating 4 hours or something. So like Leah said, and that kind of a reaction can actually hasten things.
All right, good job, guys.
Thank you all.